The following program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.
The subject of death and dying can be a very difficult conversation to have. Many of us avoid having the conversation because it makes us uncomfortable. We don't want to worry or upset our loved ones, and we really don't want to face tough questions or think about our own death. Having open conversations about death and dying allows us to prepare ourselves and our loved ones on how we would like to create our own end-of-life journey. On every episode of Guided Crossings, we will explore a different part of the dying process and offer suggestions on how to prepare your loved ones as well as yourself. I'm your host, Andrea Sebastian, and this is Guided Crossings. Palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Today on Guided Crossings, I'm pleased to welcome back Janice McDermott. Welcome back.
Hi, Andrea. Thank you for having me.
Can you please explain what palliative care is?
Sure, and you're right, it is a mystery. Mm-hmm. Many people do not have a clue. And it's been true. You know, we talked before, I've been doing hospice and palliative care for 35 years, and I think palliative care has been the hardest thing for people to really understand and wrap their head around. So that is changing, it's getting better, and you just gave a really good definition. But palliative care, so palliate is what it comes from, the word palliate, and you said it, it's to make a disease or its symptoms less severe or unpleasant without removing the cause. And that's sort of important, because when palliative care began, it was to help people address their symptoms and their emotional, their whole body issues when they had a condition that was not curable, but was manageable. So palliative care is really comfort care. And people can access palliative care when they're first diagnosed, when they're still having aggressive care, when they are just starting treatment, or further down the road when they have new symptoms or unmanageable symptoms. And it's also to pay attention to their emotional health and their spiritual health. So it really is to provide what you said, quality of life, when they're dealing with a long-term illness.
Right, and actually when I was kind of researching to do this show, I was sort of surprised about the spiritual aspect. Mm-hmm. Can you elaborate a little bit on that? Because I know that, I don't know personally, but I think that when you are given or the diagnosis of, say, an illness of some kind, I think you do try to find answers, and maybe you think more spiritually about things, and you don't know if you're not a spiritual person, that's something that you could visit if you do want in palliative care type thing.
Right.
Is that true?
Yes.
Okay.
And it's so individual, right? Because we sort of ignore that part of our being until we realize that there might be an end. And as soon as we start thinking about the finiteness of our life, we all want to find some meaning. What is my purpose for being here? What am I leaving behind? Have I been a good person? And it's so individual, and it's wrapped up in our religious beliefs. So spiritual is different from religion, but depending on our traditions and what we have believed during our life, we may believe that we need to pay for, that this disease is a punishment for something, and we believe we may need to experience some pain to pay for those sins, right? And that isn't something I can take away as a caregiver.
Right.
And it's something no one should take away, because each individual has to figure out what brings meaning and comfort to them. But I want to tell you that in my years of being with the State Association for Hospice and Palliative Care, we did surveys 3 times, twice through UNH. So they were professional surveys on mapping palliative care, basically, to see who in our state provides palliative care and what those services looked like. And then we would take sort of the answers from those surveys and look at what were things that we should improve. What should we try to improve on? Spiritual care was one of the topics.
Wow.
And we actually got a senior class of psychology students to work on that one year, which was very exciting. And we came out with a laminated pocket card that we could provide to physicians, to nurses, to palliative teams, to hospice teams that help people talk about spiritual care. So you and I have met before about difficult conversations, and spiritual care is another one, because we don't want to offend anyone and we don't want to bring up something that's sensitive or uncomfortable. And it became something on the surveys that people identified as something they think about a lot once they get a diagnosis that's difficult, that says they may be seriously ill now or in the future, but nobody knows how to talk to them about it.
Right. It's interesting. I don't know if this is still a thing. A few years back, I had a surgery, and I'm lying there and I'm in recovery, and a priest walked in, and just to talk to me about everything and how I was feeling and things like that, and it threw me. But it was okay because I'm Catholic, so I was able to answer, and appreciate it, because I didn't even think, oh, maybe I could use a priest.
Yep.
And so that, is another part of it, which is the difference between like a religion type thing and the spirituality of it.
Yeah.
But at the same time, it's sort of in the same family.
So another interesting point you're reminding me of is a typical palliative care team, and they are very different depending on what organization is providing it at this point, but they typically are a doctor, a nurse practitioner, and a spiritual care provider.
Okay. Are you asked the question then as to what you would want as a spiritual care provider? So would be in your faith, or if you're not a faith-based person, it's just a spiritual guide, or
so the people
someone
that are part of those teams are not, if they're doing their job right, they're not bringing up a particular religion unless you do. If you say, I have a specific faith and I want someone from that faith to meet with me, then yes, they would address that. But, they're there to bring that guidance around quality of life, to explore what is meaningful and what's distressing. And that was one of the things actually that came out of the work we did, was to do spiritual assessments. And there are some very good ones out there, and all the chaplains that I worked with knew about them. Okay. So distress scales, very important to see what people's emotional or spiritual distress is, and address that. So back to you with the priest coming into your room. What happens when you say to somebody who's in the hospital, either very sick or not, what happens if you say to somebody, do you want to see the priest, or do you want to see?
Right, yeah.
They go, I don't need that yet.
Yeah, yeah.
Am I dying? I mean, you just scared them.
Right,
right.
Right.
So it has to be a different approach where you're really talking about what's meaningful. And
right. And I think, just to clarify just a little bit, I think in my situation, it was a long time ago. And I think we were allowed to ask questions about religion and where, that sort of thing. So I think that for me personally, they knew that I was Catholic, so then sending a Catholic priest wasn't a problem.
Yeah.
But I agree with you 100%. If someone just kind of had walked in, I would have been like, I thought I was going to be okay. This was a routine surgery. What's happening? Right. I agree with, So there seems to be a lot of confusion between palliative care and hospice. Can we clear that up a little bit? And I'm going to say it's interesting because I'm from Canada, and in Canada, we don't call it hospice care, it's palliative care.
Yeah.
And so I'm always like, oh, they're on palliative care, good. But then it's like, well, no. And I'm like, oh, okay, because to them it's hospice care. So can you clear that up?
And some of the work of hospice started in Canada at the
Royal Victoria.
Royal Victoria.
Yeah.
Yes, and so here's the deal. So all hospice is palliative care because it's comfort care. It's a team approach towards quality of life and honoring the patient's wishes. But not all of palliative care is hospice, because palliative care is upstream. Palliative care is to alleviate symptoms. It's to manage chronic illness, to bring that symptom management and quality of life. So people can be on palliative care for a very long time. They can go in and out of care. They probably don't need it all the time. Whereas hospice is the end stage of a serious illness, and it's a prescribed plan of care. It's a paid plan of care that has parameters and regulations that palliative care doesn't have.
Okay, so we talk a lot about teams, and so palliative care, so I guess I'm just trying to kind of understand this. So I go to the doctor and I have COPD, and it's a long illness, right? So my doctor can treat the COPD, but then I can get palliative care and I have a team, another team? Like, how does that work?
That's true. So that's a really good example, because people who have COPD can be very seriously, acutely ill and get better.
Okay.
And it can happen again and again. So the advantage of having palliative care would be that a physician or a nurse practitioner who is specializing in that kind of pain management or symptom management would help their primary care doctor make it better.
Okay.
And it would also give them access to the other pieces of the team, like spiritual care, like a social worker, maybe some therapy, physical therapy, I'm thinking. So it would be a broader spectrum of team members that could address all the different distresses that are happening for that person until they feel better.
Huh. That's a really wide umbrella, because I hadn't thought of it from a physical therapy even.
Yeah.
So again, if you're having certain issues with certain, like I was thinking more palliative, like, you know, I'm undergoing chemotherapy and I'm nauseous, so I can get palliative care to manage my nausea. But then I was like, I guess I'm still not clear as to why my oncologist can't give me something to take care of the nausea. Like,
which they can.
Okay.
But I think the advantage of the palliative care team and the reason for it is really about that conversation again. It's really to set out a plan that's individualized and ask the person. It's really about listening to the person about what matters to you. What do you want to accomplish each day? What are you willing to compromise on in efforts to treat this disease or to have quality of life? So it's much more tailored to their own lifestyle, and it's somebody who can listen and make a plan. It's really about making that plan. And it's also about doing advanced directives, doing those advanced care planning documents if they haven't, or they want to change them, or they want to understand them better. So a palliative team starts there with what are your goals? What are your goals of care?
Very interesting.
And if they're not offered,
Well, I'm just kind of like, my brain's going now.
Okay.
It's like, okay, so, but what were you going to say?
Well, I'm just thinking about the fact that palliative care is becoming more prevalent. So it's existing now in more places. It's easier to identify and find. But it's not necessarily offered all the time. So when we did those surveys that I talked about, we sent them to all the hospitals in New Hampshire, all the visiting nurse home care agencies, all the nursing homes. And we said, do you have palliative care? If you do, what does the team look like? We said, first thing I think was, do you have people under your care who could use palliative care? 97% said yes, or 99% said yes. And then we said, do you have a team? Do you provide it? And they all provided it in different ways. And some of them didn't yet. They were working on it, or they referred people to other places. So it was not a full service kind of program in many places. But when I talk to people who are not in any way ready for end-of-life care, and they start telling me that their mother can't do certain things anymore and she can't be alone, and maybe now her symptoms have changed, and I say, ask for a palliative consult. And those are the words. So you can have a palliative consult. And they happen more often when you're in the hospital, when something is changing. So whether there's a new diagnosis or a new symptom, something that's not being managed well. Ask for that palliative consult. Same thing with home care. If somebody's at home and things aren't going well and things are changing, then maybe you want to ask the doctor to refer to home care or get that palliative consult in there. It can be provided in a facility or outpatient, or home care teams can go in and do those consults.
Is palliative care available to everybody?
Ideally, yes.
Okay.
But it's piecemeal is my word. So it's most insurance is absolutely. So it's like any other type of health care. It's paid for if you qualify for that service and if your insurance covers that specific thing that they're coming out for. What it always pays for, palliative care, is that conversation, that goals of care conversation. That's where it starts. So that's a really good thing that most people don't know they could have.
Right. I was going to ask you too. So let's just talk about the conversation a little bit. What are some key things they should really ask about having the conversation? Because again, you don't know down the road. But if you are diagnosed with something, it might be a recurring thing. It might be you need palliative care for 6 months and then you're good to go.
Yeah.
So what are some of the key questions if you are fortunate enough and you do ask for a palliative team? Or ask the question.
So I think the advantage is if you ask for that palliative consult, you've got a doctor or a nurse practitioner coming in who understands end-of-life care and understands your disease. So they're going to lead you through. They're going to say, okay, right now, this is where you are in the continuum of care. This is what's likely to happen. A year from now, if you're in the same place, we're good. A year from now, if things are changing, what do you want? Do you want more treatment? Do you want to stop certain treatments? Do you want pain medication? Do you want to try alternative things first? What are you willing to live with? Can you stay in your own home if that happens? Do you have people in your life to help you if that happens? If things didn't go well, what would you do and what would you want?
That's really good. I mean, because again, I think that like everything, we just think it's going to come at us at a certain way, and then we have to make those decisions. But if someone's sitting with you, you're having a consult, they're telling you what can potentially happen, and you're able to make those decisions. That's really good. Is palliative care something throughout the U.S.? I know that we're in New Hampshire, and so is it something that's, I know, like you said, it's gaining speed. How is it starting to get, more incorporated in people's care? And I think you go through your family doctor, or your, like, who provides, who do you talk to say, I need help with this? Is it your family doctor first, or, can you call a hospital and go, do you have a palliative care unit? I'm sorry, I'm asking you 12 questions at once. Okay, go, answer.
So that's why I'm really a stickler of saying to people, ask for the palliative consult, because yes, you should ask your own doctor, whoever you see the most, right? It might be a specialist, or it might be a family doctor, a primary care doctor that you've seen for years. And to ask them for a palliative consult and see where that goes would be the first line. If they know you really well and they have already a palliative team within the system that they work, hopefully they're going to say to you, I want you to talk to Dr. So-and-so, or I want you to meet with this team and think about your illness as it progresses. They can help us make decisions together. So I think just getting the word out there, just getting it in people's minds that maybe and maybe there's nothing to change. Maybe there's not a whole lot that's going to be different right now, but to start to make those relationships and those connections so that it's available, and have that team follow up with you. So it may be that they see you once and then they don't talk to you for 3 months, and then they call and say, how are you? What's happening? Those are really good things that can make you feel safer and make you feel less alone, so that when you might need more, there's a starting place.
So we talked a lot about the team, and we mentioned, a spiritual person, and what else is on that team? I didn't realize like a physical therapist can be on the team. What else could be in there?
So social work is a big one.
So when you say social work, what exactly from that perspective does a social worker do?
So again, it would be sorting out what's important to you, but it also might be financial needs, or it might be, are you going to be able to stay living where you are? And if not, what are the options? Do you want to think about those options? Do you want to have a friend or a family member take you to look at some alternative housing options? So it's really, again, individualized to what might come up for this person, and have them start thinking about what might they need. And it's things we avoid, right? So the advantage of the social worker is they're going to bring things up that maybe you didn't want to think about, but it's time to think about.
Right, right. Are things like food, like if you need transportation to a doctor's appointment, is that under a palliative care umbrella, or like if you need meals or light housekeeping? I know, you know, that sort of thing. I don't know if that's in that umbrella.
They would certainly address that and ask if there were things that might help you, and they would probably give you resources. So they would probably give you the names of organizations in the community that could be resources for those things, and again, sort out what your personal care team looks like. So who is it that you can call on or count on? Is there a family member? Is there a neighbor? Who is it that's your core? And who do you want, right? So that's an important piece of it, is who do you really want to have come and help?
Well, and I think that's important. Like we talk about that all the time, is, you know, your knee-jerk reaction is always maybe a family member, but that doesn't necessarily mean that that person is your best person, you know? And I guess if you're dealing with a care team, the other side that I think would be really good too is if you do have a good palliative care team, it gives, you know, with your physician and their office, and that they're able to focus more on what your actual illness is per se, right? And not have to worry. Well, they should worry, but you know, their care is being taken care of with the palliative care team, sort of thing. Is that how that works? So the two should be in contact.
Totally.
Is it the palliative care person who talks to the physician? Like, how does that work?
Yeah, I would say the palliative care team, whoever it is, would give the primary care doctor or the specialist, whoever it is, the overview of what they've done and what they suggest to go forward, and they would work together on that. They wouldn't replace the person's primary doctor.
Right. So, and palliative care can be done anywhere.
Yes.
Right? Whether you're in the hospital, hospice, at home.
Yes.
Okay, so that isn't a big problem for getting it.
No, but it's not ongoing care. Like, you know, if you qualify, so again, it depends on the situation. You might qualify for home care for a while, services, because of whatever it is that just happened, whether it was an operation, whether you did have some procedures done, or whether you've just had managed symptoms. So there can be some regular care for a while, but it's probably not going to be ongoing.
See, this is really interesting, because the whole time we're talking about palliative, and you'd think I'd understand it by now because we've talked a lot about this. So in my head, I'm thinking palliative is the stage before hospice, but it's not that, because you're saying if you had a surgery and you need help, you can have palliative care, which you wouldn't be necessarily talking if you had like knee replacement. Can you have, or is that not?
Well, so yes. So this is where I get into it. This is where it gets so confusing.
Did I open another can of worms?
You're just identifying all the confusion around it. So yes, some teams might offer palliative care after a knee replacement.
Right.
But my historical knowledge of palliative care and the intent is when someone has an illness that can't be cured, but it can be managed.
Okay.
So your COPD example, perfect. End-stage heart disease, or, you know, not even end-stage, but serious heart disease, dementias, you know, things that are going to progress, but we don't know how quickly. So there might be some symptom management needs along the way. There may be needs for changes in lifestyle or the place you live, So as things are progressing, palliative care can come in and make recommendations and get you in touch with other services that you might be able to use. Yes, you're right. Palliative teams may very well suggest to someone that they are now ready for hospice, or would they accept hospice if they get to a point where that would help them. But it's not an immediate thing. It's not like you get on palliative care and then you get on hospice right away.
Well, and I think that's what's so confusing is that for some reason you always hear palliative care / hospice.
Well, yes.
And I know that you're trying to change that, and I applaud you for that. And that's why I like this conversation so much, but that's how it's always seems to be.
Well, and back to our survey, that's exactly what we found out. And I know this to be true, that when people are offered palliative care, most often it's when they are really ready for hospice.
Okay. Wow.
So it has historically been that kind of in-between time when you start to get people to accept the fact that things are nearing the end. But it's a kinder, gentler way to get the care started, but it's not the intent. So you're absolutely right that people are working really hard now to separate the two.
Right.
And let people have the advantages of palliative care way before we're talking about
well,
end
and
of
just
life.
talking to you, like the advantages are huge.
Yeah.
I think it takes a lot of stress off a lot of different parts of just being sick. If you have a group of people collectively being able to take care of you, and you're just working on getting better. And I think to your point too, you said it earlier, people do get better.
Yeah.
You're not necessarily always going to have palliative care.
Right.
But I think statistically we can say if you're on hospice care, it's pretty much the end. And I know there's success stories with that too, but that's,
Well, and people worry that they have to give up things when they sign on to hospice, which that's a whole other conversation. But you don't have to give up anything when you're on palliative care. And ideally, you don't give up anything on hospice either. You choose to let things go so you have more quality of life.
Right. Which is, again, why we like to have the conversation so that you can try to figure this out prior to the situation being dire. Yeah. Right. Any final thoughts?
Oh, I think we've covered it.
We did good.
Yeah.
Okay, good. Well,
So
thanks for
thank you for
being
the
here.
opportunity.
You are welcome. I love seeing you. So that's all the time we have for Guided Crossings. We'll see you next time.
The preceding program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.